I am Nanda Kishore. I'm anthropologist by training, as you rightly said, and I started studying anthropology with the understanding that we are studying human society, and then the society is quite varied. What we come to understand of society till we systematically engage with it is quite superficial. But once you start engaging with the society systematically and trying to understand society, I think in the process of my training as an anthropologist, I have come across that society is very unjust, and you have people from different sections of the society, living in very unequal conditions. So actually, in that context, anthropology has opened up my mind to look at this sort of inequity existing in society. And as I was training in my discipline of anthropology, we had to do a project as part of our training to go and live with a tribal society, because anthropology still in India is popularly in this framework of tribal studies, studying the other. You go out and live with them and try and understand their issues so that you come back with an enriched understanding of the inequities. And in that process, I realized that one of the key issues plaguing the idea of development is lack of access to health. So that prompted me during my masters because as a part of my training, I did field work among Adivasis in Andhra Pradesh, among Kondareddis, who are one of the so-called primitive tribal groups. Now they are rephrased. So if you look at those people, they are able to sustain because they are close to the nature, but the whole idea of disease, the idea of health seeking, the idea of treatment is something which was very different, and then that actually is contributing to a lot in terms of the inequity, accentuating the inequities, not allowing them to participate in the development initiatives. There is a sort of a friction because of the health as an important factor, is what pushed me to get into this medical anthropology, one of the subsects, sort of a part of anthropological orientation, where you focus on the health and illness component of any culture or society, and then try and unpack it so that help for us better understanding how do you integrate health into development. So that was the main impetus which pushed me into this aspect of public health, where you try and engage with health as a central axis for the development as such. That's what my journey was. That's an interesting question, because I think, as you rightly said, anthropology is not a known discipline in India. Not many schools offer it as a course. Very few courses, very few universities do offer this as a course. But I think what I started with after my master's is I wanted to pursue further specialization in medical anthropology. So I started to understand this role of health in the context of the whole development discourse, especially focusing on the tribal Adivasi inhabitants. And I moved on from that to work in the development sector. And then in the development sector, my role as an anthropologist was to actually explicate these issues of like social and cultural factors around health. Because in the dominant discourse, health has always been restricted to these ideas of access, ideas of services, rather than what is actually the processes which influence these issues of access, or they influence these issues of health seeking, issues of health systems. I think as an anthropologist, I was more inclined to understand these processes. So I started as a researcher in HIV AIDS a program in Andhra Pradesh. Then it was Andhra Pradesh. So I was more looking at these issues about stigma, issues about gender-based violence, and how do they contribute to this epidemic of HIV AIDS. So it was very interesting because I also was working with a team of about 3 or 4 people who are from different disciplines, especially from economics, especially from the clinical trained doctors who are trained to work on HIV/AIDS issues, and management people. But as an anthropologist, my unique contribution, I would say, was to bring about different perspectives on the social and cultural aspect of any condition, or the social and cultural processes which lead to a manifestation such as lack of access or lack of human resources in health systems. So I started off with HIV/AIDS, and then I progressed on to talking about issues around social and cultural issues around tuberculosis, and then later I got into the ideas of pediatric HIV/AIDS, how children are living with HIV/AIDS in the context of losing their parents, and what acts as social and cultural factors which could be helped in the program side to develop a social support and holistic support for the children who lose their parents and siblings. So it was an interesting journey, and then as an anthropologist it gave me an immense scope to unpack a lot of social and cultural factors associated with health. I think social determinants, or the idea of social impact on health, has always been there. It has always been existing in different discourses, in different disciplines, in different forms. But I think what's this social determinant framework brought back social sciences argument into the health discourse is, I think it played a role in trying to redraw the focus on these issues like poverty, issues like the disparities in the society, the social injustices existing, or the lack of thinking of what could be the fallout of the policies. I think this sort of approach brought back a need or a fresh outlook into the discourse on health, which was slowly migrating or gravitating towards more of a clinical applied aspect, I would say, because it was all about solutions. How do you apply a quick fix solution in terms of a very pragmatic way of addressing these issues of health systems, rather than trying to look at what actually contributes to these social issues. That was lacking, I would say, just because the disciplines were getting more polarized, and then the idea of health was more being confined to the medical part of it rather than. So that way I think social determinants approach, I still have a problem with the way the idea of determinants is being pushed, but I think I'm happy that at least this argument has got back these concepts which are slowly getting sort of digressing. Now they're brought back to this table for us as public health researchers or people who are concerned about larger health disparities to be considering these issues on a broader sense. I think, in a way, I'm an anthropologist. I'm also, have this issues with SDH's approach itself as such, because it's again brings in the positivist elements of measuring the disparities, or it's more of again focusing on the numbers of it. But I think as public health researchers we have to be open to the idea of multiple sources of evidence. Numbers certainly do have a role to play, no doubt about it, but I think in this sort of public health, what we're talking, this idea of social determinants is being reduced only to sheer numbers is a problem. For me, I would say, because evidence is just not only numbers. Even one case could throw a lot of light on the issues of health or the complex scenarios of health systems in the society. So I would say it is currently the dominant paradigm is very positivist in terms of numbers, epidemiological data sets, or random clinical trials, some sort of frameworks which are driven by this idea of numbers and is dominating, but as an alternate idea of bringing about the narratives to work in tandem with these numbers is what I would say. I'm trying to be unbiased because there always is a talk about how these soft sciences do not have any solutions; they only raise questions. They are the arguments against social sciences and others like anthropology who talk about narratives. But I think I'm still, even though there's a lot of sort of discrimination in this interdisciplinarity of public health when you talk about the numbers versus narratives, but I still do not see a reason why we should not have as wide as an evidence possible. Along with numbers, you should have narratives. For example, the recent work for my doctoral studies was on farmer suicide. So some states have said within a year there's a drastic reduction of numbers of farmers who committed suicide. And interestingly, some states have said there are no suicides, farmer suicides. So how the numbers are being used vis-a-vis how the narratives of one farmer committing suicide writing a letter to the President of India stating that, see, this is what the condition of farmers is. And then the letter draws an attention to the plight of the one farmer, contextualizing the farmer in the larger social, political and geographical canvas. For example, this farmer was from Vidarbha. So these numbers could be used and misused. Narratives will add a very powerful dimension where you can't, ignore one letter to the president by a farmer who is committing suicide. So look at the strength of it. And as a policymaker, should you be only concerned about the numbers, or should you be also considering one letter written by a farmer who is committing suicide to the President of India? So what is evidence here? These are the questions which still there are no answers, but I would say it is important that we are open to the idea of different sources of evidence, however numerically strong or less they are. I think we all talk about these days about evidence-based policy making, and I strongly feel we all are aware of the fact that we are still lacking in this interweaving the evidence with policy making. Policy making traditionally has always been from top down approach, where few educated policymakers sit together at a table, and then that's a classic idea of policy, and then it's now translated and transmitted to the people across the system like photocopies. You give this as a template, and then you are expected to follow it, and then you are monitored whether you're following it or not, or with an indicator, set of indicators. I think that's been a idea of a policy which is largely prevalent in Indian context. I think that's the case in majority of the nations, developing nations. So I think for me, they're still wanting in terms of linking up evidence with policy. But having said that, there are certain initiatives where are taking serious this idea of research, creating a body of evidence, and then evidence being translated into policy. I still feel that's still an area, a gray area when it comes to the using evidence as a policy. But there are certain good examples. For example, if you talk about public health, HIV AIDS, the scenario of HIV AIDS has brought in a different paradigm of policy making. A lot of studies or RNTCP, Revised National Tuberculosis Program, you have revisions based on some operational research studies. And then these studies were fed into the policy making, taking stock of what a policy is, how is it being implemented, and can we plan it, change it, reorient it, and then rephrase it in a different way. I think there are some good examples, but I still feel that we have a long way to go in terms of knitting the evidence into policy. That's, I think, my feeling. And then also the idea of vertical programs have benefited with this evidence seeping into the policy. But I think larger development programs, I think there's still want of this idea of evidence and policy making having an intersection. I still feel there's a long way to go. one of the problems I have with the current set of researchers is the way you ask a question, because all the research or all this idea of acquisition of knowledge starts with the question in your mind. I think unless you have a sort of orientation to the students to ask a question differently rather than falling into the mainstream trap of asking questions which fit into a particular program, or we fit into the idea of numbers, or they fit into idea of re-articulating the concepts into applied aspects. I think there's the track there where it doesn't encourage students to think originally. For me, I think any program or any course should open up the idea of a research, idea of the student more towards questioning things critically, asking questions differently, so that it opens up more questions than answers. For me, I think that's a message I would give for many of these young research scholars or public health students, because they always are forced to align with the mainstream thinking of what public health is, and that inadvertently fixes them to this idea of using larger tropes of epidemiology, numbers, or applied aspects. I'm not denying the importance of them, but I think the students should be encouraged or equipped with these ideas of trying to open up and asking questions differently and critically is what I think is a message I would give.